I have the honor to introduce our speaker, who is Professor Dorothy Rabinowitz. And I have a biography here of hers, which you don't want me to read the whole thing because she has done so much that it would take too long, and I'm sure you want to hear from her rather than from me. So I'm just going to highlight a few things that Professor Rabinowitz is known for. So firstly, she is the 14th Penn Integrates Knowledge Professor and George A. Weiss University Professor of Law and Sociology at the University of Pennsylvania, with joint appointments in the departments of Africana Studies and Sociology and the Law School, where she is the inaugural Raymond Pace and Sadie Tanner Mossel Alexander Professor of Civil Rights. She is also the founding director of the Penn Program on Race, Science, and Society. I'm sure a lot of you know her books quite well, but I'm going to mention them. She's the author of Killing the Black Body, Race, Reproduction, and the Meaning of Liberty, Shattered Bonds, The Color of Child Welfare, and Fatal Invention, How Science, Politics, and Big Business Recreate Race in the 21st Century. Of course, there are many edited volumes she's worked on, and she has written so many articles in scholarly journals and essays. She's also a member of the National Academy of Medicine, a fellow of the College of Physicians of Philadelphia, and a fellow of the Hastings Center. I'm delighted to welcome Dorothy Rabinowitz here.
Thank you. Thanks for that introduction and for all your efforts to bring me here, and to all the sponsors and to all of you for staying this long in the day after we've been fed so much by knowledge and food. It's an honor to be able to talk to you about this important subject. So I'm going to talk about an aspect of racial injustice in public health that has to do with the growing trend to rely on genomics as explanations for health inequities and lots of other kinds of inequities as well. And I'll start with an example. All of you are very familiar with lots and lots of examples of health inequities in the United States, but I want to use this just as a jumping off point. And this is an article that was in Chicago Magazine about a study conducted in 2005 and 6, looking at the differences in death rates from breast cancer between black and white women in Chicago. And Chicago is an extremely segregated city, and so most of those deaths of black women occurred in segregated, impoverished, or low-income neighborhoods in Chicago. And the researchers found that black women, although they actually had a lower incidence of breast cancer than white women in Chicago, had twice the death rate, were half as likely to survive for breast cancer, which translated into hundreds of needless deaths. You know, as the researchers said, had the black women had the same death rate as the white women, there would have been hundreds who survived every year. And one of the intriguing aspects of the research was that they found that the problem wasn't that black women's health had declined, but just the opposite, that in 1980, black and white women died from breast cancer at exactly the same rate, and then this gap emerged over the next 20 years, so that by the time the study was conducted, black women were dying at twice the rate, but it was because white women's death rate had been cut in half. And kind of, this is an issue that was raised before about where disparities arise. Here, it was clear that the disparity arose because of the privilege that white women had to have access to advances in mammography, other forms of cancer detection and cancer treatment that occurred over those 20 years. And the researchers concluded that this had to do with the lack of access to health care and living conditions that would support survival from breast cancer in Black neighborhoods in Chicago. Now, this I think is a clear example where we can see that the reason for this terrible health inequity is because of structural forces that disadvantage Black women living in Chicago and advantage white women living in Chicago. And yet, there continues to be research looking at what are the genetic explanations for why Black women have higher rates of death from breast cancer. So I want to talk a little bit about the history of where this idea comes from, that the reason for health inequities is because of some innate difference in the people who have poorer health versus the people who have better health. And I think we have to go all the way back to, and this goes back to, I think, some of Dr. Ford's comments this morning about what racism is and what race is, go all the way back to the invention of race. And I say that race is a political invention. I learned working on my latest book that the problem with saying it's socially constructed is that many people see saying race is socially constructed is perfectly consistent with saying race is a natural biological division of human beings, which is socially constructed. And so I like to emphasize that race is purely invented. It's an invented category. And if we can trace its invention to a period of European exploration, conquest, genocide, and enslavement of other peoples, and the need to come up with a justification for that, especially among Christians, where you weren't supposed to enslave people who were converted to Christianity, so you needed to be able to say they were a different kind of human being that could still be enslaved even if they were converted. So something to provide a justification, but also a way to classify people to determine who it is that gets to be an enslaver and who has to be an enslaved person. And race was the way in which Enlightenment scientists explained these divisions between human beings and justified the type of exploitation and genocide going on at a time when science was supposed to be advancing beyond pre-modern ways of understanding humanity to the Enlightenment that was supposed to be more empirically based, more rational, and also be in line with political philosophy that was changing as well to support liberty and tolerance and equality. And so you have European Enlightenment scientists grappling with how to have a society, help a society govern this division, political division, at a time when it was supposed to be advancing beyond pre-modern concepts. And so what the Enlightenment scientists did is they supported the idea of equality and liberty and tolerance and empirical methods and rationality, but they only supported that for white people. And they imported, into this advanced scientific revolution that we still revere so much, they imported pre-modern concepts of creationism. All of these scientists today who claim that somehow they're advancing the science of racial difference are actually creationists. And they're taking a theological concept that God created human beings in different races, that some force of nature produced race. And they imported that into supposedly advanced modern science. And continues to happen today, where we have people who believe that they're very advanced, very intelligent, they're at the forefront, the cutting edge of science, and they continue to use pre-modern concepts about some force of nature dividing human beings into races. I also say that science was a racial invention in the sense that it wasn't just that these European typologists were inventing race, but race then became critical to the way they conducted their science. And so I think in ways that we haven't even fully explored, like even the focus on finding differences as so important to understanding human beings, whether they're racial differences or other kinds of differences. But the idea that you can't understand human beings without dividing them into races and then comparing the races, that idea that's so prevalent today, so much so that many scientists think they can't even conduct a study without doing that, right? That was a way in which these pre-modern notions shaped the very way that science was conducted. And so race becomes very embedded in scientific knowledge and practice at the same time that scientists are embedding a concept, an invented concept of race, into popular notions, political notions about human beings. And of course, goes without saying perhaps, or let me mention that they didn't just divide human beings into these supposedly natural races, they also always made Europeans at the top of the hierarchy. They put them in a hierarchy with Europeans the most beautiful, the smartest, the most civilized, the least violent, as they were going around literally killing people for their land. They still presented themselves as less violent than the people they were killing. And just to give an example of this, Thomas Jefferson, one of the founders of the United States, and writers of the Declaration of Independence, which again promoted liberty, equality, tolerance, but they wanted to promote those views while still enslaving African people and excluding them from all of these benefits of Enlightenment thinking. And so Thomas Jefferson employs this method of saying that it is because of the natural distinctions between races that we cannot include black people into our new democracy. It's not a political decision, it's based on natural distinctions that prior philosophers would have said God created. Now we say nature created, and as I'll show today, they say, well, evolution created it. But it's still the same idea. Once upon a time, some natural force divided human beings into these large groups called races, and because of that, we have inequality in the world. Now, another aspect I'll speak about briefly is the way in which gender intersected with racism during the slavery era to produce this concept of race. And as slavery expanded and was embedded into democratic principles of the United States and institutions, race became more and more cemented into U.S. culture and politics. And part of that was the idea that black women produced black children who were disadvantaged because of reproduction, because of black women's reproduction. Bettina Druggett, I thought in her talk, in her poetry, emphasizes connection between racism and reproduction and black women. If you think about it, everything is about, reproduction. And that we can trace all the way back to the time of slavery. In my book, Killing the Black Body, I trace the regulation of black women's childbearing from slavery to the present day. But one aspect of it that I've thought even more about in my recent work is the way in which race is seen as something that's naturally reproduced, and that making black women the reproducers of black children who could be enslaved is an idea that continues to this day, the idea that black women reproduce the disadvantage of black children, and that the reason why black children don't do well in school, are locked up in juvenile detention and adult prisons, their health deteriorates eventually, they have higher chance of dying before the first year, on and on and on, all has to do with problems in black women's wombs. And this was actually the first law passed in the colonies, established this when in 1622 in the colony of Virginia, the white people, white men, there's Englishmen at the time, got together and they had to deal with the question of what is the race of the children who are being born to black women and fathered by white men. And this is such a great example of how we can see race being invented. But they invented it to pretend like it was natural. So they have to decide what to do, you know, and of course it should be, well, there are children, they're the children of privileged white men, their children should have that status. But instead they decided the opposite. They decided that no, number one, we want to create a pure white race because we have to identify who are the people who get to be privileged, who can be owners of other human beings, who cannot be enslaved. Who are those people? And the best way to classify those, to identify those people, is to say they have to be pure white. Okay, that concept, 1622, we still have today in America. But don't tell me it's natural, it's invented. I can tell you what it was invented, right? They have to be pure white, and look at the advantage we have, and we can enslave these children. That expands the assets that we have to work for us to build up our racial capitalist system and get rich off of other people's labor. And so they decided, they passed a law that said that these children would have the status of their mothers. And to me, it's not only the invention of race, but it's also the beginning of this idea that black women reproduce the disadvantaged status of their children. Something we see over and over again in public health. I mean, in public health, black women's fertility is a problem that needs to be understood and fixed and addressed, and again, as Bettina, or get rid of it through sterilization or stigmatizing or other ways. Okay, so also in the United States, during the slavery era, the racial concept of disease was developed. And that is the concept that people of different races have different diseases and experience common diseases differently. Again, this concept animates all of medicine today. And so it's taken for granted. It's taught in medical schools and in internships that people of different races have different diseases and experience common diseases differently. But where does that come from? It comes straight out of slavery, and one of the biggest promoters of it was Dr. Samuel Cartwright, who trained in Pennsylvania, including at University of Pennsylvania Medical School, which, by the way, trained many Southern doctors. Most of the students at Penn were white, well, clearly white, but they were from Virginia. The largest number of students at Penn Medical School from Virginia in the 17 to 1800s. And one of the students who trained there was Samuel Cartwright. He went back to the South, as many of these doctors did, and he was commissioned by the Louisiana Medical Society to study the peculiar diseases of the Negro and write a treatise about it. And he found all of these diseases that were peculiar to black people And just like Enlightenment scientists developed a hierarchy of race that put them at the top and helped to justify slavery, his findings all were findings that justified enslaving black people. And so, for example, he found that black people had a mental disorder called trichomania that caused them to flee plantations. But his major idea was that black people had lower lung capacity, and that therefore, in order to be healthy, they had to be forced to work. And so black people who were not enslaved had poor health because their lungs could not vitalize the blood sent to the brain, and those who were enslaved had better health. And so slavery was actually good for black people for medical reasons. Again, an idea we can still see circulating in medicine and public health today, that certain treatments that actually you would not use on other people, except black people, are actually good for black people. If everybody tells me I'm going to give you a treatment that's not good for anybody else, but it's good for you because you're black, I'm going to be suspicious of that, because in America, we don't give treatment to people who are black that's better than the treatment for other people. And so, but it comes out of this idea that treating black people for their peculiar diseases is good for them, when in fact it is a way of promoting racial injustice and subordination. Now, this idea is so embedded in medical practice today that it is automatic in some medical procedures. And I'll just point out one: glomerular filtration rate, EGFR, which is an estimate that helps doctors determine kidney function, and it automatically is adjusted for race, but for black people. The same element, the same protein in the blood, same amount. It's not that black people have a different a different function. It's that the same reading, the same measurement, okay, for that is in one patient or another, is produced as a different number for black people automatically. And so, and you can see from this that the higher the number is closer to normal, which means that black people are more likely to be read as having normal kidney function than other human beings who have the exact same measurement of kidney function, right? And this has implications. Number one, that you're less likely to be referred for follow-up care if you're black than if you're any other human being. And it also means you're less likely to be determined qualified for a kidney transplant, because it's read to be less concerning. Again, so you get this, it's, if I go to the doctor, if I'm black, I can have one reading for the exact same body, one reading. I'm black, a different reading if I'm considered not to be black. Okay, automatic. The spirometer, which was invented in England but came to the US, and Samuel Cartwright helped to perfect it and also helped to create this idea of race correction in the machine, continues to be used in the US in some cases with a button for race, so that, again, the same measurement of air, okay? If it's a black person, it's determined to be different, to have a different implication than a person of another race, based on the assumption that black people, as a race, categorically have lower lung capacity than other people. And so what's normal for black people is abnormal for people of different races, embedded into medical practice and public epidemiology and some aspects of public health as well. This also has implications in cases involving asbestos poisoning there have been cases where you have a black plaintiff and a white plaintiff with exactly the same amount of harm to their lungs from working in the asbestos factory. The white patient gets more damages based on the assumption that the black patient's lung capacity was lower to begin with. And I've just learned that in the NFL concussion cases, black patients have to prove more damage because it's assumed that they had lower intelligence. Yes! I could go on and on. We could spend this office, Tina had her story, and I could go on and on with all of the forms of race correction that go on automatically. So when doctors say, well, we're using this to better refine our treatment of the patient, but then I say, oh, but you're automatically, categorically determining that black patients should be read differently than any other human being. That's not refining anything. That's actually, I would say, poor medical practice. Well, this was mentioned earlier, undertreating black patients for pain. And I use this as an example to rebut the argument that this is a benefit to patients to treat them differently by race. And so one of the most egregious examples of how it's not a benefit to treat patients based on race is the many studies showing that black patients are routinely undertreated for pain and get far less pain treatment than white patients with exactly the same injuries. Now, in response to this, doctors will say, well, that's because black people, I'm culturally competent. I was trained to be culturally competent. And we learned in cultural competency class that black people have a culture where they're taught not to show their pain. This is one reason why cultural competency is not the answer, because it's often teaching students stereotypes about people, which then just lead to them to accentuating the race-based myths that they have when they came into medical school. So I like to then show them, well, what about little children diagnosed with appendicitis in severe pain, where, I don't care how much cultural training they got, they're have appendicitis and they're in pain, they're not going to hide it. And so these doctors know that these little children are suffering from extreme pain, and yet they prescribe opioids dramatically differently to white children and black children. And here I'll say a little bit about the idea that this has something to do with the opioid epidemic. I absolutely believe it does, and Helena Hansen at NYU has done some work showing this as well, that doctors have, many of them have, a stereotype where they believe that black people are predisposed to drug addiction and white people are immune from drug addiction, and therefore it was okay to prescribe and over-prescribe opioids to white patients. I think it has to do not just with insurance, not just with access, but with racist stereotypes about patients. And it's an example that does show how racist stereotypes can harm white people as well as people of color. I do want to add, though, that another thing shown, though, by the opioid epidemic, which began among white patients, but now has spread to others, is the way in which it's being treated that is so different from, for example, the crack epidemic of the late 1980s, early 1990s, and the sympathy that is given to white opioid addicts compared to black crack users at that time, crack cocaine users, in a number of ways. You could just look at the loss and despair, the explanation is loss and despair, as opposed to this group of people is predisposed to drug addiction and criminality, and the fact that it started there and then moved to the black community. No one says, look at these horrible white people who spread the drug addiction to black people. no, that's not even part of the media or research analysis of it. Another thing is that it's, whatever the explanation is, it's not that white people were predisposed to opioid addiction. It's a sociological explanation. You know, whatever you think the despair was caused by, it's still researchers looking for social factors that led to it. And so we know that social factor, when it comes to white people, if it's negative, it's not caused by their innate flaws, it's because of the social conditions they were forced to live under. When it's black people, it's because of their innate predisposition to some pathological problem that is the explanation, and it continues to be the case, or to their genes. So just looking at the difference in research approach shows you that yes, we can have a public health discussion that focuses on social determinants, but only, you know, white people. It's another advantage that white people have. The other thing is, this loss and despair business, I think, lets the white people who are dying off the hook. I mean, I have sympathy for them. I think it's an injustice, it is, but part of it is that they have many of them have an investment in whiteness that causes them to support policies that are harmful to their health. And here I would highly recommend reading Jonathan Metz's book, Dying of Whiteness, where he shows that low-income and impoverished white people who are dying because they do not have good health care oppose universal health care. This is a big difference between black people and their situation. Black people say, we need universal health care. This is unjust. We should have access to health care. The white people he interviewed said, I don't care, I'd rather die than have those Mexicans and black people have Medicare and Medicaid. I'm putting on my Tennessee accent. But literally, he's white, so they would tell him how they really feel. And that's what they said. And he analyzes how these very people who are at high, whose mortality rate is going up, oppose policies that would lower their mortality rate because of their investment in whiteness. And to me, that's where whiteness is the most critical, because it causes white people to think that their whiteness, which is their superiority to other people, is even more important than their health. The other example Metzl gives is the other cause of this spike in mortality, besides drug deaths, the other is suicide. Most of those suicides, the vast majority, are self-inflicted gunshot wounds. And Metzl points out that, again, in the states that have the highest rate of suicide by guns, they have the most resistance to gun control. And when you ask them, these white people, why they oppose gun control, even though they can see in their families the people who are the result of guns is family members being killed or them killing themselves. But that's what those deaths are from. They're not from robbers coming into their home and killing them. They're killing themselves, or they're killing their loved ones in the home. What their response still is, we need our guns to fight off the black people. You know, they still think that guns are a sign of white privilege and white power and white strength. And again, their investment in whiteness is killing them. And it's such a powerful example of the power of racism that will even lead people to oppose policies that would save their lives. But whiteness is more important than that. Now, a recent study shows that, as I have long suspected, that this undertreatment of black patients for pain is connected to stereotypes about bodies. It's connected to the racial concept of disease. This was a study conducted at University of Virginia Medical School among medical students and residents who are treating patients, and they found that a substantial number of white medical students and residents held false beliefs about biological differences between blacks and whites. Beliefs like black people have thicker skin than white people. Okay, this is 21st century residents at University of Virginia. And I don't believe they're the only school that there were people holding beliefs. Black people have less sensitive nerve endings than white people. And therefore they believe that they were properly treating black patients by giving them less pain relief because they could not, they were physically incapable of feeling pain because of these biological differences. And why do they think this? My opinion, they didn't study exactly the origin of this, but my opinion is they came to medical school believing these myths that they learned, and then they get to medical school and every class they take says, well, black people have this kind of body, and white people have this kind of body, and Asian people have this, and Native Americans have this, and you should, the first thing you notice about a patient should be which racial category they fall in, and then you should diagnose their disease that way, and then you should also use medical tests that embed within it the view that black people actually do have different kinds of bodies, all black people categorically do, and then you should treat them that way. So it's reinforced in medical school. So I'm not surprised by this. It's horrifying, but it's if you're training students that way, it's not surprising you're going to end up with results like this. Now, when the human genome was unveiled, the mapping of the human genome was unveiled, it seemed as if there was going to be some radical transformation of medicine, biomedical research, public health, to do away with race-based approaches. And when I say race-based approach, again, I'm talking about this biological concept of race. And I will distinguish that from a racism-based approach, okay? So there's something innate in people of different races that produces these inequities in health. And Clinton and everybody else, Francis Collins also, Craig Venter, they all made a point of emphasizing that the map of the human genome showed that there was no race at the genetic level. Clinton highlighted the similarity genetically among human beings, but I think even more important is the point that they found that even that tiny amount of difference is a lot of genetic variation. You know, you could look across this room and see lots of genetic variation, but it doesn't fall into the categories we call races. That's the main understanding. And so yes, we should study human genetic variation, but not based on racial categories. That's a hindrance to understanding human genetic variation. At the same time, though, I was shocked to see that there was this reporting of a new project now to actually look for genetic differences between human races. So Nicholas Gray reports on the front page of the New York Times that that's the next stage of the Human Genome Project. And I was curious about this. I started doing research into it and found that indeed there was this resurgence of interest in gene-based differences between human beings, between different races, in order to understand and health inequities. Although I think that's the case of the tail wagging the dog, where they wanted to do this research, and so they tack on, oh, this is going to help and health inequities, which will help them get research funding and support, even though the genomicists don't need too much help. It's the ones studying social determinants of health would need more help with funding than the geneticists do. But, so I ended up writing a book called Fatal Invention, where I argued that there is a new biopolitics of race at foot, with scientists defining race as a genetic grouping, and you can find this very commonly in scientific journals, peer-reviewed scientific journals, either explicitly in the article defining race as a genetic grouping, stating that race is is a genetic grouping that resulted from evolutionary changes, or it's implied, because actually most studies don't bother to define what they mean by race, but they're implying that it's a genetic grouping because they're looking for genetic differences between races. Then what happens is that there are these genetic explanations for racial inequities that persist in a supposedly post-racial world. And I'm talking today because you all are interested in health inequities, but this research is going on to explain inequities in educational attainment, in incarceration rates, and lots of other things as well. And then we see the biotech and pharmaceutical industries producing race-specific remedies based on an assumption that the reason for these race-based differences in health are because of some innate genetic difference. There was a study published in 2000, and what was it? Do I have it there? No, anyway, 2008 or so. 2013, okay. That looked at, it was a content analysis of articles that were on race and genetics, and looking at whether the researchers treated race as if it were a biological category, which is RR for racial realists, versus the researchers treating race as a social construction. And it found that when the human genome was mapped, there was a slight dip in the racial realists, the use of race as a biological category, in other words. But afterward, a huge spike they found in articles on race and genetics that treated race as if it were a genetic category that could, with races that could be genetically distinguished and identified. So I want to give you some examples of the kind of research that's being done that is based on this new genomic concept of race related to health. And so we know that the U.S. stands out among all developed, I think it should be developing, because it seems strange to me to say that the advanced country is the one that has the high, where the mortality rate is going up, right? But the developing countries, actually, it's going down in most developing countries. And in parts of the U.S., the maternal mortality rate is higher than in many developing countries. Especially when we look at black women who are 4 times more likely than white women to die from pregnancy-related causes. So this is an area where there's been some research, including research that, like this, that looks for the genetic explanation. And this is a study that was published in a premier journal of obstetrics and gynecology. And the hypothesis was that black race, independent of other factors, increases the risk of preterm birth and its frequency of recurrence. What is black race? What does that mean? Black race. How much blackness do you need in you to have this essence of blackness, right? That causes this problem. And how do you separate it or control for all the other factors that could affect preterm birth? I just think this is a bad hypothesis, because there is no such thing as black race independent of other factors, and it would be very hard to control for all the other factors besides whatever black race is that affect preterm birth. And the researchers didn't control for even a fraction of what we could today shout out as possible factors that would affect it. They didn't, for example, control for experiencing racism, just as an example, or living in a segregated neighborhood. You know, I could go on and on for all the things they did not control for. But they, when they did control, they found that in the study, the black women, the people they identified as black women, still had higher rates of preterm birth. They said that concluded that it suggested a probable genetic component that may underlie the public health problem presented by the racial disparity in preterm birth. Interesting to add the public health aspect to it. When this was not a public health study and was not conducted in a way that was attentive to public health, but it's kind of, you know, they kind of hedge reaching a really strong conclusion by using words like suggest and probable and may. But the point was to show that it was genes that could explain this. And then they get a headline in the New York Times that says study points to genetics and disparities in preterm births. So if you didn't read the study or you weren't critical of what the study said or found or how it was conducted, you would think that the reason for the public health problem of differences, racial differences in preterm births, was because of genetics. And this happens all the time that you get reports of studies that are poorly conducted and don't actually find that genes are the cause, and they get reported in the media without much, I mean, maybe I'm being too harsh, I'm sorry to be so harsh, but in many cases the researchers do not issue a statement that says, no, we did not find that. In fact, they give interviews that make it sound like that is what they found, when they actually didn't find it. Then we have the technological response, which is to create medicines and other kinds of technologies based on this idea, rather than addressing the structural causes, coming up with a therapy. And Vital, which was approved by the Food and Drug Administration as a drug for African Americans to treat heart failure, is one example of this. I won't go into this long story that shows that it was for commercial reasons that it became a drug for black people. Jonathan Kahn has written a whole book about it. But I do want to point out that there was absolutely no basis for deciding that the FDA should approve this as a drug for black people, and their justification for even going down that path was that we're using self-identified race as a surrogate for genetic markers. So again, this common idea that black people's bodies operate differently for genetic reasons, or that they react to drugs differently for genetic reasons, was assumed in the very concept of approval of this drug, even though the FDA was not presented at this point in the investigation of the efficacy and safety of the drug with any genetic information whatsoever. The cardiologists who developed the drug did not develop it based on any genetic information. It was based on combining two generic drugs that had been prescribed without regard to race for 20 years prior to that, because the drug, the combination, dilated the patient's blood vessels. And that's why the drug worked. Yet the FDA, in announcing the drug, says it represents a step toward the promise of personalized medicine. And in so many ways, the idea of personalized medicine marches on completely completely in step with race-based medicine, and many people continue to think that race-based medicine is more personalized. And to me, it's less personalized if you treat me by race. But the FDA accepts this idea that treating people by race is a more individualized, personalized way of treating people. But again, what is that based on? It's based on this concept of racial differences that are categorical and automatic, and an idea that we can even tell biologically, identify biologically what race somebody is. Now, that idea, everything I've talked about so far, has been contested for a long time. And W.E.B. Du Bois contested the idea that black people had poor health after emancipation because their bodies innately could not adjust to freedom. It's commonly thought, as Cartwright said, that black people were innately predisposed to being in better health if they were enslaved, and therefore when they were set free, their health deteriorated because they were innately unsuited for freedom. This was a public health theory. It was the dominant public health theory. And Du Bois contested it in the Philadelphia Negro, and he added also a political, structural twist to it by saying that the same ideas were circulating about Irish people when they were unpopular. In other words, politically unpopular. There's also a lot of research being done now on how structural racism affects health. Chandra Ford talked about her own research and other research this morning. There are lots of examples I could give. One interesting example is looking at the impact of living in a state that has higher levels of structural racism, and that being connected to heart attacks. And as an op-ed piece of the American think of racism literally, the way that I capture it in Fatal Invention is that what we're seeing is the embodiment of racism, not of innate genetic predispositions. Race is in the biological category that naturally produces health disparities because of genetic differences. It's a political category that does have biological consequences because of the impact of social inequality, in particular structural racism on people's health. I think one of the mistakes that researchers make when they say, well, we can do this research that treats race as a biological category today because we're not racist. So they will say, well, Samuel Cartwright was racist. He supported slavery, and therefore his use and promotion of race as a biological category was wrong because he was using it to promote racism, but we're using it to end health inequities. So we're doing a different kind of research, and I think one of the mistakes that's made in that kind of thinking is that it's based on an idea that race is a natural category, and then you can use it to be racist or not racist. But in fact, that's not the relationship between race and racism. Racism came first. First came the desire of Enlightenment scientists to create a system that would allow for the enslavement and conquest and extermination of people. And then racism, they were racist. Then they said, okay, we need race in order to support that system. Another example I'll give is the Racial Integrity Act passed in 1924 in Virginia, where the state said we want to preserve white purity, and we want to preserve the power of white people to dominate. And so we are going to ban interracial marriage. We want to, it was passed alongside the mandatory sterilization law. Eugenics and Jim Crow going hand in hand. And then they wanted to maintain white supremacy. Then they said, well, in order to do that, we need to tack on to this law a racial classification system. And let's figure out what that racial classification system should be in order to promote racism. But the racism comes first, and then you have to invent race to support it. And so, continue to promote the biological concept of race is racist. You can't say race is natural and I will promote that view as long as I'm not racist. No, that view itself is a racist view. Now, I thought that Chandra Ford and others today gave lots of examples of how we could actually make change and eradicate these false views of humanity that cause so much damage, which is another reason, even if you don't believe anything I said, ask yourself, have these ideas helped to reduce health inequities? No, not at all. I mean, the things that have to reduce health inequities is structural change. We know that, structural change. Promoting medicine based on a false view of race, I can't think, even people will say, well, what about sickle cell anemia? So, okay, sickle cell anemia, say it's a black disease. Show me how that has helped black people with sickle cell anemia. What has it done? It's caused people to be arrested, women to be told they shouldn't have children. It's caused people to lose their jobs. It's caused people suffering from pain from sickle cell anemia not to get treatment, to be told they're drug seeking, they can't get treatment. It's caused it to get less funding than other genetic diseases. Compare cystic fibrosis, seen as a white disease, to sickle cell anemia. So no, that's not even a good example. It's on the other hand, ask me how the biological concept of race has caused harm. I can show you millions and millions of people exterminated on the basis of it. So, however you want to approach it, scientific evidence, moral evidence, historic evidence, I just do not see how an argument can be made that it improves health. So, let's say we accept that, what do we do? This is going to be very broad brush, and again, I think we saw today some more concrete examples, and I'd love to hear other people's ideas, but doing research that accounts for structural racism and state violence. This is a big problem where research is done that is looking for explanations for health inequities, and it completely leaves out structural racism and state violence. It completely leaves it out. So even researchers that are looking at the biological effects of racism often end up focusing on the biological aspects of it and leave out the structural part. So the result is the interventions are all about treating the biology instead of ending the structural racism and violence that is a cause of the problem. I can say more about that later if people are interested in what I mean by that. That confronts the politics of science. This idea that science is neutral, I still hear this, it's incredible, but people will say, well, no, we can do race-based research as long as it's neutral. Well, but everything about that is political. And why it's being supported as opposed to other kinds of research is political. And so why it gets a headline in the New York Times is political. And then being willing to put racial justice at the center. I really appreciated Dr. Ford's comment that my research is anti-racist. But there are people who say, oh, you're adding ideology to your science. As if the ideology isn't already there, embedded in the science. And so you become idealized. You mention anti-racism, you're ideological. But if you do race-based science based on embedded racist ideologies, you're neutral. That's so common, right? That way of thinking. And then lastly, some of you might find this helpful, especially the physicians, but I think we have suggestions for public health and researchers as well. Jonathan Metzl, who I mentioned, wrote Dying to Whiteness, and I co-authored a piece in the AMA Journal of Ethics called Structural Competency and Structural Racism. And we are promoting a view, a practice, a pedagogy of structural racism that is being attentive to structures of inequality and privilege, as opposed, and that being the focus as opposed to cultural competency. Although, they may go hand in hand, but as I mentioned, there are times when, without being structurally competent, cultural competency can be the rehashing of stereotypes about racial groups. And there, we suggest that researchers and practitioners should confront racism, not try to pretend they're being neutral and hide from it. All of these points have been raised today. Learning from the social sciences and humanities, poetry, for example, to understand the meaning of race and structural racism. A big problem I found in working with biomedical researchers and physicians and others in the medical field is that they have never thought about what race means. They've never had a class that forces them to think critically about it. And sometimes just having a conversation, getting people to think critically, makes a big difference. Being creative and collaborative in addressing structural problems, and a lot of times health practitioners say, well, I can't solve all these problems in my lab or in my clinic, and it requires sometimes working outside there with other people and collaborating in creative ways to figure out how to address the structural problems that we know are causing health inequities. And then speaking up more about the structural issues that impact patients. So we can get out of our offices, our labs, our clinics, and become politically active. People in the health field have a lot of clout. As you see, they get headlines in the New York Times. And so let's see more headlines about structural racism and the need for radical change, as opposed to what increasingly is getting the attention of supposedly finding race-based genetic differences to explain the inequities in health that we see. Oh, one last point, the last slide. Which is just an overall way of thinking about this, is that the best way to improve health, I think this comes out of everything we've heard, including the talk about whiteness, what is it that would improve people's health the most, is a more just society. That would improve everybody's health, and we need to work better at how to take whatever fields we're in and move them toward creating a more just, equal, and humane society. So I'll end there, and I'm happy to take questions and engage in conversation about this. Thank you.
Thank you so much for
Sure.
that, Professor Rabinowitz. So just to let everyone know, from 5 p.m. we have a reception that will be held here. So you're welcome to stay. We have 20 minutes for questions and answers, but I'm sure there are a lot of people who will want to talk to you for more than the time allotted. But in the time we have we got any questions for Professor Rabinowitz?
Thanks for the talk.
Sure.
So I wonder if there's anything sort of at the grant funding agencies or something
Yeah.
that encourage this type
Oh,
of research.
yes.
So, yeah, because the
Yes.
suggestions at the end were directed at the sort of
That's
individual
true.
scientists. So then,
That's true.
what are things that can happen at the sort
Yeah.
of institutional
Yeah.
level in sort of discouraging this type of
Yes, as I was
research?
just having a conversation earlier about the need for higher level policies that are directed to incentivizing research on the structural forces as opposed to the genetic forces, because right now, the incentives, I'm sure lots of researchers here are feeling this, to include genetics in research, and I'm not saying it should not be included, but the problem is, it often then gets so lopsided toward a focus on genetics, and genetics becoming the answer. I see this over and over again when there's, you know, a collaborative project between sociologists and geneticists, for example, and there's that new field, sociogenomics, and the answers tend to be about the genomics. And all the structural part gets washed away because there's this popular interest in it, and there's more money to be made in the genetic end of it than there is in ending structural racism. And so the funding incentives are toward that. Also, NIH, its requirements about recruiting in certain clinical trials, participants by race, is broadly interpreted to mean that you're also supposed to look for differences by race, report your results by race, and your conclusion is supposed to be a racial conclusion. So that's another example of an incentive. And then in terms of the practice, the standards and policies that people feel they have to abide by in order to practice good medicine is also a problem. The exams are a problem. You know, there's just all of these structural forces that are pushing toward race-based approaches, biological race-based approaches. And I think that we do need to look at how to change those high-level policies that are, as we're also changing work on the ground. I mean, I think it's all important. We have to do all of it. That's what the thing is, because at every level there's work to be done. It doesn't matter what you do, you can be involved in change. And so I absolutely agree with you. I'm now working on a project related to University of Pennsylvania's acknowledgement of its entanglement, and especially the entanglement of the medical school with slavery. And I'm calling it the Penn Medicine and the Afterlives of Slavery Project, and wanting to do something concrete to eradicate the ghosts in the clinic, the bad ghosts in the clinic. And I'm finding that at every level, you know, I'm working with student organizers that are trying to change the curriculum, but at every level, there is a higher up level that can almost eviscerate whatever progress you make with these very powerful incentives to stay the same, you know, not to change. And that's something I think is really important. And those are some areas where we can work. One more is the standards for publication on research involving race, requiring a definition of race, a justification for why you're using race. I think if you're studying racism, there's a justification for using race, but you should, if you're not, you know, you should be forced to explain why race is important to your study and how you are defining it. That might help as well.
Actually, that was
Should
the
I-
answer to my question.
Oh, okay. Yes, I will let the gentleman with the, I see a hand over here, there was a hand up here too, but I'm going to stand back and let you.
Okay.
Yeah, this gentleman, and there's a, where is that?
So I noticed you had the slide about, like, basically a more benevolent view of race, where people are perpetuating the idea of race, but this time to medically benefit
Right,
black people.
yes, yes,
And
yes.
I've actually talked about this same subject with a few people in here. We're not basically, basic medicine.
Right, right,
But I'm seeing it all over the place. I'm from Baltimore,
yeah.
and
Gentleman is back.
Anyway, I was a teacher at Northern High School, in fact. I don't know if you forget. And so like a lot of the ideas that I hear people talk about that are like, ideas based on liberation and stuff. Like Tommy Curry actually points out that the term toxic masculinity was actually coined in the 1800s specifically to describe black males, right? And just those ideas, I've seen it in white school psychologists who interact with children in special ed and stuff, right? And I wonder if you can maybe say a little bit more about other ways that can be maybe just a little bit more nefarious than people really want to, because we talk about it all the time, like these ideas, like how it's the exact same thing people were saying in the 40s and 50s.
Yes.
But now you just have a different reason for saying it. And I wonder, is
Right.
that, okay.
Yeah, no, absolutely. You have a different, I'm doing this research to benefit disadvantaged children, helps to say children, and it's usually black children, and I'm adding genetics to it, and that somehow makes it more accurate. So, one example I'll give is educational attainment. So it's very popular now to do research looking at how genes produce different levels of educational attainment, looking at polygenic scores that supposedly explain differences in educational attainment. Now, some of the research will also use sociological data and say, well, we're trying to see the interaction of genes and social conditions, but in the end, what the recommendation is, we need a genetic test either to predict who will have high educational attainment and who will have low, or to really understand the extent to which genes are affecting low educational attainment versus the impoverished environment that these children come from. Well, in either case, you end up, whether the sociology is added or not, you end up with a conclusion that a genetic test is what is going to be the method for improving or reducing inequities in educational attainment. Now, and they will say deliberately, in fact, there was an op-ed piece somebody wrote in the New York Times about this, saying that, and also that mentioned me, along with Lenin, as someone who opposed biological research, saying, well, we liberals should take this up because it's going to improve educational attainment for disadvantaged children. So it's presented as if this is a positive for disadvantaged children, when it completely ignores the structural reasons that impede these disadvantaged children's education. And it presumes that somehow genetically testing children, unlike what's happened in the past, is going to benefit these children. If they're shown to be predicted to have low educational attainment, that's who's supposed to be benefited from this. When in a U.S. history has a genetic test that shows you're predicted to be less, now they don't use intelligence anymore, less intelligent, have less potential for achievement, when has that benefited anyone? Every example of it is that they have been disadvantaged, including sterilized, but some people, that would never happen again, even though it happens to this day. But they've been separated into classrooms where they're given inferior education. And so That's one example where we see these ideas about genes and social inequality playing out. But the criminology is rife with this idea that genes explain gang banging, explain the use of weapons, and in all of them, even if they don't mention it, now some of the studies are about African American children. Some of them don't mention race, but even if they don't mention race, we have such a long-standing connection between these false ideas about black people and lower intelligence and higher criminality that it's impossible. It's ludicrous to say we can conduct this research and come up with these kinds of conclusions without any racial implications. And so whether they're saying we're doing this to help black children or we're not. I recently had the privilege of having an onstage dialogue with Ibram Kendi, whose new book is How to Be Anti-Racist. And he says in the book, it's racist to say there's something wrong with black people. Now that might seem extreme, but it happens to be something I've been going around saying a lot too. There's too much research that's focused on what's wrong with black people. That's not the research should be what's wrong with our racist, white supremacist society that's producing these bad results for black people. But race isn't the risk factor. Racism is the risk factor. There's nothing risky about being black. And it's just racist to think that black people are risky, innately risky. That innately have problems. No, that's not the case. And I really applaud him for just boldly saying, if you want to be anti-racist, stop saying black people have problems. The black people are a problem. But something's wrong with black people. Look at what it is in our society that is causing problems for black people. Did you see the difference between those two questions? And I think you're right. It seeps through so much of research, a whole industry around identifying what's innately wrong with black people, which to me, I might offend people, but I think it has a lot to do with white researchers who they really don't want to face the implications of white privilege and white supremacy. And so they continue to circulate these ideas that the reason for all these inequalities are because of something wrong with black people. And I'm focusing on black, it's also something wrong with Mexicans or something wrong with Native Americans. And my work happens to be mostly about concentrating on black people, and I'm more steeped in the myths and stereotypes and approaches about that. But this reluctance to really grapple with racism in America and all the harms that it continues to cause, and deflecting it onto what's wrong with black people, and then justifying by saying, well, we're trying to help black people. Why are you so mad at me, Dorothy? I'm just trying to help poor black children in Philadelphia by studying their brains and pointing out the defects in their brains caused by poverty. That's a literal conversation that I had with a colleague. So, but there are lots of people do I don't want to point out any individual person. It's a whole supported way of thinking about it. That's the liberal approach. It's not the white supremacist approach. It's the liberal approach, and that's something that I think we just need to radically change the way that we approach these questions in research and policy.
You
Microphone.
Hi, thank you so much for giving
Oh,
this
yeah.
talk.
Sure.
I just wanted to say, so I'm a student who wants to go into medicine
Yeah.
eventually, And I was just wondering how you suggest medical students and future medical students deal with this idea of like these classes of cultural competency
Yeah.
and what impact we can make
Yeah.
when we go on to practice medicine.
Yes.
So if you have any words on that.
Oh, I think students can make a huge amount of difference, and it's kind of, the other day I saw I can't think of her name, the Swedish, Greta, yes, okay. And she was saying, how dare you say that I'm your hope, right? You've devastated my world. How dare you say I'm the hope? So I feel more, after hearing her, feel more nervous saying, well, medical students are the hope. But I really do think that right now, these ideas are so embedded, as I put it, even in the very technologies, they're so embedded in medical practice, so hard to shake them, that it's going to be very hard to make any kind of radical change with the people who are controlling the profession now. And that's not to say that the people who are already practicing physicians shouldn't be organized and activated about this, and many are. But it's really my hope is when I see students like I'm working with at Penn. We have 2 organizations on campus that are working with the administration to demonstrate how these racial stereotypes pervade their education, and they go class by class. They have done the homework. They go class by class, textbook by textbook, and point out how false biological concepts of race are being taught at Penn Medical School today. And again, just like University of Virginia, I'm not singling them out, it's everywhere. And they've gone to the dean's office and said, we want change, and now they're working on it. And this is going on in other universities as well. So, and in a way it's unfair because medical students are the most disempowered people in the school, and because they're depending on faculty and physicians to give them approval so they can practice medicine. And so there's a lot of pressure just to go along, get good grades. And so I think I really admire the brave students who are willing to organize and say, we want change, and to show where change needs to take place and why it needs to take place. But that's going on. So, wherever, are you in medical school now? Or you're thinking of going?
Yeah, I'm a 3rd year undergraduate.
Oh, wow, well, bless you. I think when you get to medical school, look for students like that who can organize to make change, both within the school and outside the school as well. And work on, reading groups, discussion groups. I also, at Thomas Jefferson Medical School, a group of students there created their own seminar. And then the following year, it has become part of the medical curriculum there. So I could give lots of examples of where students have done great work to try to make a change. And I think that's where the hope lies in the next generation, not just accepting what the prior generation. I said to Bettina, one thing I really liked about her talk was that it showed how generation after generation these ideas are passed down. When she said, who taught you and who did you teach? They're passed down, and we just don't see change. Somebody has to intervene and say, no, it stops here. We're not going to do this anymore. This is wrong. It's unscientific. It harms people, and we want to practice medicine differently.
We're running out of time, so can we take just 2 more questions at the same time?
Oh, okay.
Sorry, not at exactly the same time.
Like Bettina, history.
Your comment about Greta Thunberg actually
Yes.
made me think of Little Miss Flint as like another, but not aspirational, not giving them the UN platform for the work
Yeah.
that she's been doing. since Flint still doesn't have
Yes,
clean water,
right,
right? And we're
exactly.
seeing, you know, now there was a recent article that came out about how the children of Flint, there's like they all have lead, a lot of them have lead poisoning at this point.
Yeah.
And so I was wondering, like, in terms of what you're talking about, in terms of how there's this focus on the human genome as a source of kind of understanding what deficiencies are, like how the conversations about environmental racism that actually impact people on a public health level, like on a very deep level, like how and if
Yeah.
that those conversations are being had. And
Yeah.
another question the other question I had was about, and I can't, from having read and taught from Fatal Invention,
Yeah.
I think I get your position on it, but the public attachment
Yeah.
to the genetics of
Yeah.
race through products such as
Yeah.
23andMe and
Yeah.
Ancestry.com.
Right.
Like, what do you think is the hope of us actually detaching
Right.
from this idea that race can be
Yeah.
genetically
Yeah.
found out?
Yeah.
I love that setup. I think it's, my question follows similarly. I'm someone who works primarily in philosophy of science, and I work an awful lot on explanation. So when I was hearing you talk, one of the things that came to the surface for me is just that I think there is a very strong normativity to explanations in science. And so I'm wondering to what degree an important part of this story is both a sense in contemporary science of the relative hierarchy among scientific disciplines, so the fundamentalism that says we should push towards the physical sciences as the archetype, and there that the norms for explanation are very strongly reductionistic. And so let's go to, in effect, the elementary particles. When we transfer that to a biological setting, then it becomes very natural to push for genetic explanations. And they're limited in all sorts of ways. So this is one example, but I think we see lots of other examples of the way in which we kind of hitch our wagon to thinking that genetics is going to explain everything. And it's connected to some very general, deep conceptions of what it needs to explain something scientifically. So I'm just wondering whether that seems like it fits with your project.
Absolutely. Yeah, those are great questions. Okay, so environmental racism. I think that there is some very wonderful and helpful research being done about how residential segregation makes people vulnerable to conditions that harm their health, and one of those conditions is the proximity to toxins, or the ingestion of toxins, or however they get into your body, breathing them in. There is good research being done on that. Now the question is, of course, okay, we know that, what's going to be done about it? And on the other hand, there is also a way in which the research that by some scientists that don't have an anti-racist approach to it ends up doing, and sort of what you're saying, looking at, okay, now there are all these biological harms to these children. They've been damaged, and it's almost like it's an innate condition they have, because the idea is all these black children born in Flint, Michigan, or living in Flint, Michigan, have lead poisoning, which reduces their cognitive capacity. And so again, if now your focus is on what's wrong with those children and fixing that, instead of fixing all the structural inequities that led to the lead poisoning, it can be a harmful scientific approach. And so again, it's I distinguish between the new and the old biosocial science, in the sense that the old said biological differences produce social inequality, like eugenics, for example, or the bell curve, or lots of the research I've been talking about. There's a new way of saying, well, no, it's social inequalities produce biological differences, which is better. So you recognize that structural racism produced Flint, Michigan, and produced these harms to these children. But if you don't have a structural approach to it as a scientist, you end up in the same place as the old, which is these children are damaged, something's wrong with them, we need to intervene on them, and they're not, the fact that they don't have the opportunities other children have is because of their internal, there's something wrong with their bodies. And that, I think that's something we have to be careful of. I'm so tempted to keep going. I heard this talk by a researcher who was looking at lead poisoning. He gave a great talk about how lead poisoning is concentrated in black neighborhoods. And then he said, now we're going to connect it to criminality of black children. No, I raised my hand. The first thing was, guess what? You didn't create that idea. There have been black people fighting against environmental racism for a long time. In fact, during his talk, I was looking up the name of the person who coined the term, spewed it out. And then I said, why don't you deal with solving that? Why go on now to do research on the predicted criminality of these children? That just now turns your research into a harmful approach instead of what could have been something that was actually helpful. The products. So these gene-based products marketed to consumers are part of what I said, with the biotech industry taking up these ideas and making them into marketable products and making money off of it. And I do believe that it reinforces this view of biological race and the view that genetics determine everything and can explain everything. And I think that the biological concept of race and the view that genetics determines everything, I think they're linked together. And this goes to also an answer to your question. And what I was saying at the beginning of my talk about the racial invention of science, I haven't had a chance to explore this deeply, but I think maybe philosophers, something for philosophers to take up. But I think there's something very fundamental, like deeply, deeply embedded in Enlightenment scientists' incorporation of creationist ideas and framing them as if they're progressive and modern, when it's actually their reductionist ideas. And the fact that the reason why they took what was supposed to be an advancement of science, progress in science, and actually went backward. Like they took something from the past and put it in what was supposed to be progressive, was because it supported racism. And so racism has been an impediment to science in a deep, deep way. In the this reductionism of biology. I just wonder whether biology has to be reductionist or whether or not became reductionist because it supported racism. Do you see what I'm saying? I think it's really deep, in a way we haven't quite excavated enough yet. And so, but there's definitely this symbiosis of creationism, reductionism, biology, and racism, and figuring out those connections and trying to disentangle them, I think is really important to creating a science that's anti-racist.
So thank you so much.